Thank you, Madhuri, for your introduction. Can you see my slide?
Yeah, we can see.
Okay, thanks a lot for your introduction, a lengthy introduction, and thank you to the PCOS Society, Dr. Duru and Dr. Uday for giving me this chance. My topic is risks faced by PCOS woman who is now pregnant. Just one second. Now, you all agree that PCOS is a disease or a syndrome with a very wide spectrum, starting from young age, pre-pubertal, up to the older age group. In the younger group, it's mostly a reproductive disorder. And later on in life, it has a lot of metabolic issues associated with it. Certainly, getting pregnant is difficult, often difficult for this group of women because a lot of them suffer from infertility. But being pregnant itself can be quite complicated. So of all the phases of PCOS, the question that we are asking today is, do PCOS women have higher risk of adverse feto-maternal outcome? And the summary answer seems to be that there is a trebling, 3 times risk in maternal complication in women with PCOS when compared to healthy controls. So why is that? Let us just spend 2 minutes to look at the pathophysiology. We know that in PCOS women, there is an inherent insulin resistance, hyperandrogenemia, dyslipidemia, and a low-grade cellular inflammation, which is universal in most PCOS women. Other than that, they are a very heterogeneous population associated with many comorbidities, diabetes, hypertension, atherosclerosis, dyslipidemias, etc. Obesity being one of the major things. And many of them suffer from infertility and therefore have become pregnant as a result of infertility interventions, treatment, ovulogens, injections, IVF, etc. Also, there appears to be some amount of abnormal placentation, which I'll show you in my next slide. So pregnancy complication in women with PCOS, apart from being many inherent problems of PCOS, could also be the result of a primary subclinical dysfunction of the placenta, which is a genetically induced PCOS problem. At a hormonal level, testosterone appears to be a major driver. And at a protein level, the placental signal transducer activator of transcription 3, PSTAT3, appears to be a major promoter. So low-grade cellular inflammation, which is exacerbated by pregnancy and is often associated with high LDL, triglyceride, inflammation markers, enhanced endothelial dysfunction. So this enhanced endothelial dysfunction and inflammatory changes in pregnancy and alteration in the trophoblastic invasion alters remodeling of spiral arteries, reduction in uterine artery impedance, reduction in reduced depth of endovascular trophoblast and abnormal placentation, and which leads to, which has also shown at a microscopic level various changes associated with vascular lesions like chronic ciliitis, intervillositis, and abnormal villus maturity. So to summarize or to put it in one slide, pregnancy complications that we see more in PCOS women could be because of the multiple history that they have, obesity, insulin resistance, etc. Could also be because of multiple pregnancy, infertility drugs, treatment, etc., androgen excess, but also a primary placental alteration in gene expression, which is inherent to PCOS women and leading to pregnancy complications. Now, the maternal and fetal complications that are most associated with PCOS women are early pregnancy loss, miscarriages, early trimester losses, hypertensive disorders like PIH and preeclamptic toxemia, gestational diabetes, prematurity. In the neonate, small for gestational age, macrosomia, increased perinatal mortality, which also includes stillbirths, low Apgar at birth, congenital anomalies, and as a result of many of these obstetric complications, are increased C-section rate. So let us examine each of these associated complications in a little detail. And when I speak to you today and show you various data, I'll be taking data from two major publications. The latest that I could find. This one was a pregnancy-related outcomes for women in PCOS, 2017 review that reviewed about 35,000 plus non-PCOS women against 3,600 PCOS women, and another huge publication, a review of three major meta-analysis about neonatal and maternal complications in PCOS, covering, as you can see in this slide, 750 women, PCOS against 4,500 controls, 5,000 PCOS women against about 120,000 controls, and equally huge study. So I'll be quoting all my data from these two major reported studies. Early pregnancy loss, we all know that we have a feeling that early pregnancy loss is increased in PCOS women. It is 3 times increased risk of EPL according to various publications. The only thing is we are not very clear, because this is not absolutely proven. We are not clear if the higher BMI, ovulation induction drugs, IVF treatment, etc. are the main driver for increased risk of early pregnancy loss, or it is something intrinsic. It has also been shown that metformin and laparoscopic ovarian drilling before getting pregnant might reduce the chances of early pregnancy loss. Does PCO increase ectopic pregnancy? In this recent, population-based huge study, I did find a mention of ectopic pregnancy being increased statistically significantly in PCOS women against controlled, against a control of non-PCOS women. Although I'm sure that this is not something which has been proven. Both early pregnancy loss and ectopic pregnancies are seen more, but they are not absolute in evidence. Now, GDM risk is increased 2 to 3-fold, even after adjusting for pre-pregnancy BMI. What we know is that lean PCOS are at lower risk. Obesity and family history have, women with family history of diabetes have a higher risk. Pregnancy weight gain increases the risk, and a coordinated diet, exercise, etc. reduces the risk. And because of GDM, there are various maternal neonatal complications which are increased, like cesarean sections, shoulder dystocia, macrosomia, stillbirths, prematurity, polyhydramnios, and birth defects. Pre-eclamptic toxemia and PIH are also shown to be increased 3 to 4-fold in PCOS women. Again, even after adjusting for BMI and ART treatment. Women who are more hyperandrogenic appear to be at greater risk. Preterm delivery is also increased twice compared to controls, although the data for stillbirths is not very clear, but it appears that stillbirth rates are also higher in women with PCOS. Fetal and neonatal outcomes in women with PCOS, the data regarding this part about the fetal neonatal outcome is inconclusive, like I'll be showing you in some tables. So this huge data showed PIH, preeclamptic toxemia, GDM, preterm delivery increased in PCOS women with the odds ratio of almost 3, 4, 2-fold, 3-fold. So this is has been shown with good data. However, cesarean delivery, preterm delivery, upgirths, birth weights, stillbirths, perinatal mortality, etc. have a odds ratio of just about 1 to 1.7, 1.4, 1.5, similarly for all these variables, although it is shown to be statistically significant. One other major question is there increased risk of congenital anomalies in PCOS women? If we have to go by data, it shows that women with PCOS have a very statistically significantly higher chances of major anomalies and even of any anomalies. When broken down, 2/3 of increased risk is for cardiovascular, or CNS anomalies. Cardiac is the most common, which includes great vessel anomalies. Central nervous system like spina bifida and encephalitis are higher, as are skeletal like cleft lip, cleft palate, caudal regression syndrome, ureteric duplication, and anorectal atresia. These are some anomalies which have been associated specifically more in PCOS women. So, maternal complications, the four main complications are certainly increased. Neonatal, we are not 100% sure, but they seem to be more associated with PCOS women. But the bigger question is, what about offspring health, which means the long term health outcome of children that are born to PCOS women? So, do PCOS offsprings have a poor start to life? Let me show you the Barker's hypothesis, which is an excellent, we know this hypothesis, which says that the intrauterine environment is what determines individual's future health. In fact, when one is pregnant also with your grandchildren. So the eggs that may someday become a grandchild are developed inside the daughter while she's still in the womb within the mother. And these eggs, how they are nourished, in what kind of an environment, is very, very important. That's what Barker's hypothesis tells us. And we know that in PCOS women, their intrauterine environment appears to be, is very different from that of a non-PCOS control, at least in terms of hyperandrogenemia, hyperinsulinemia, and many other, environmental milieu is in the hormonal milieu is pretty different compared to a non-PCOS. So the long-term risks of a female offspring, we all know, is higher risk of developing PCOS. It has been shown that daughters of women with PCOS have increased LH, testosterone, even if they don't have full-blown PCOS. They have hyperinsulinemia. That appears to be mostly because of a genetic component, but the environmental component, which means intrauterine programming, appears to be a very important driver also. Risk to male offspring, increased body hair growth, premature male balding, insulin resistance, increased risk of coronary heart disease has been shown. Mechanism is not very clear, but again, the cause appears to be intrauterine milieu. So the key points is, all children of PCOS women appear to be having an increased cardiometabolic risk. Female offsprings have a higher risk of PCO, and female offsprings have higher risk of autism disorder, and the chances of childhood obesity is a little more. So prevention is what we look at in our endeavors always when we are dealing with our patients. PCOS, we have understood and we know has profound implications on the health of a woman and health of her future offsprings. Not only that, we know that PCOS itself is a big, huge problem now. It's a global epidemic. We don't have Indian data, but I picked up this data from somewhere which says that PCOS annual impact on the US health system is to the tune of $4.36 billion, which is a huge amount of money. How do we, and of course, gestational diabetes is a global problem, and it is more so. These are some data of prevalence of GDM in amongst pregnant women. I'm not going to read it, but what is important is that we know that in Indian women, they appear to be 10 to 11 times at greater risk for gestational diabetes compared to their Caucasian counterparts. But that is also because we are highly diabetic prone. We are the thin fat Asian group with huge visceral obesity and body fat. And therefore we know that we are very prone to diabetes. So it's not unimaginable that gestational diabetes also should be very big in our country. So how do we what interventions can we do to reduce the impact of PCOS on pregnancy outcome? One of the best ways is pre-pregnancy optimization. If you happen to see the patient before she's pregnant, this would be the best choice, and it would not be a cliche to say weight loss and other lifestyle changes is the core. It's the mainstay of prevention of any complications related to PCOS or their pregnancy outcomes. The aim should, of course, be normalize sugars, normalize lipids, hematocrit, proteins, and vitamin D. So basically, the point would be to screen the PCOS woman for various metabolic disorders that they may be having, manifesting or not, otherwise harboring in their system, and try to correct it as much as possible by lifestyle changes. And most important is that if we counsel our patients that their children PCOS, them having PCOS increases their chances of their children of childhood morbidities, long-term morbidities, and perinatal complications, is very, very important. Once the patient is pregnant, we know in the first trimester, apart from again lifestyle changes, a universal screening of diabetes GDM is a must for our population at least. We can also consider screening for PIH, preeclamptic toxemia, by doing various biochemical markers, including NT-scan and etc. Increase and add to everyone low dose aspirin, high dose of folic acid, and control weight gain in pregnancy. That I mean, my previous speakers have spoken very nicely about exercise and diet in pregnancy, but it would be worthwhile to put your PCOS woman to a dietitian and make sure that they have a very, very targeted increase in weight gain every month, and not uncontrolled weight gain like they do in pregnancy very often. Prophylactic metformin for prevention of GDM. This is not, I mean, I would not say it emphatically because we don't have enough data regarding that. But we know that adding prophylactically metformin, I would probably do it for somebody who's obese and who has a family history. But I really don't have good data to tell you that every PCO patient should be added metformin for the prevention of GDM. Control weight gain, I said. Intensive screening by biochemical markers, and fetal echocardiography is one additional test other than the regular pregnancy scans that we do. And intense monitoring in the third trimester by way of regular NSTs, fetal daily movement charts, and regular Doppler studies, etc. And maybe a, I don't know, again, if all obstetricians would agree, elective termination of pregnancy around 38 weeks may be considered. I'm sure there are other speakers who are going to speak about how to treat and how to screen. So to summarize my lecture, available data suggest that women with PCOS have a 3 to 4-fold increased risk of PIH and preeclamptic toxemia, and a 3-fold increased risk of gestational diabetes, even after adjusting for confounders like um, BMI and other treatment for infertility. After adjusting for many confounders like, I'm sorry, I read this wrong. After adjusting for many confounders like IVF treatment, infertility treatment, BMI, and other risk factors, it appears still that PIH and preeclamptic toxemia and GDM is about 2 times higher in PCOS women. Adverse outcome varies in different PCOS phenotypes. Again, very important. The hyperandrogenic phenotypes definitely will have more chances of complications. Data on miscarriages, preterm delivery, and neonatal health are very few and very contrasting and heterogeneous. However, they certainly appear to be more than controls at this time of what we have published data. Impact of being born to a mother with PCOS on long-term child health is still very unclear, but appears to be important, and more research and publication population data is required for us to understand that, and women should be informed of the greater risk of adverse outcome since they are PCOS. Thank you very much.
Thank you, Sujata, for that lecture. And as we do not have questions, when you were talking about metformin, So there was a recent paper which was published in 2020, which has said that use of metformin pre-pregnancy and during pregnancy has definitely reduced the incidence of GDM.
Yeah.
Though the meta-analysis, which was published in 2019, says that it is basically controversial and probably we require uh, more RCTs to prove whether
I think,
breast
Madhu, what
satisfaction.
happens is that very often people have the question, if the patient is already on metformin when she got pregnant, we have reasonable data, and then we would at least want to continue till 12 to 14 weeks. But the patient who has not been on metformin before being pregnant, that
No,
is where I think we have more doubts as to what could
no,
be
no.
the case.
That the paper, which was the meta-analysis, which was published in 2019, talks about whether we should or we should not continue metformin to
Ah,
prevent complications in PCOS, and it says that there's no consensus which has been reached, and because all the RCTs which were analyzed in that data basically were controversial. If
But
it,
I think in clinical practice, we all are continuing metformin and
yeah.
yeah.
till 3, even though the Indian FDA says that give it after 20 weeks of gestation. But I think most of us if the woman is on metformin, we definitely continue it.
Yeah.
And I think,
But the question is, would you start it for prevention of GTM?
yeah, that is something which
Yeah.
probably, I
No.
don't know, maybe Shashank will answer
That is
that question
No,
because
no, there's one paper which was published in 2020, and which says that probably you can start to prevent GDM.
Yeah, that's what I had shown in that.
Yeah, so that was a paper, I think, in
I think among the
Clinical
endocrinologists,
Endocrinology and Diabetes Journal. I think
Pia
Pia,
is online.
Pia could also tell
Give
about
your
that.
inputs
Yeah,
whether
so the data is controversial. I think as a matter of practice, all our patients of PCOS are, we know they're insulin resistant. A big majority of them are going to be on metformin. If they have, a little bit of maybe um, hyperinsulinemia or obesity or irregular periods, they are likely to be on metformin. So I don't think we would discontinue it. It's true. But like Dr. Kar said, I doubt that we are prophylactically from a pregnancy planning point of view going to start metformin. That I don't think we have consensus anywhere on that yet.
That's true.
Yeah.